If you look at the prevalence of diabetes today, we see that the prevalence is increasing across the globe. And today in India, we have about 77 million people with diabetes. And the number of cases in the South Asian region is significantly increasing. About 75% increase is happening every year. In the South Asian region, we are saying that 1 in 11 adults have diabetes, and India accounts for about 1 in 7 of all diabetics. The number of people living with diabetes is predicted to increase by 69% to 152 million in India by the year 2045. Another important reason is that 50% of the people with diabetes are not yet detected. They are at very high risk of presenting with complications. And today, if you look at the number of deaths because of diabetes worldwide, there are about 700,000 deaths occurring because of diabetes, and 1 in 4 live births are affected by hyperglycemia in pregnancy also. So that is a huge burden. By early diagnosis and effective management of diabetes in pregnancy, you can influence the development of diabetes in the future generations. If you look at the incidence rates also, diabetes and pre-diabetes are very high, or any degree of dysglycemia, if you look at it, the prevalence of this is very high in our country, in the particularly in the South Asian region. If you look at it, people are in a phase of pre-diabetes which can progress to diabetes, and therefore we need to be aware of screening such individuals and picking up pre-diabetes early, so that we can apply interventions which can prevent the progression to diabetes. Now, if you look at what has happened in the last 20 years or so, if you look at from 1999 to 2016, there has been a significant change. These two maps actually are showing the prevalence of diabetes across the different states of the country. And you can see the bluer zones are the lower rates of prevalence. As you can see here in the chart here, the prevalence rates, as you go from light blue and go on towards darker red, you are seeing the prevalence rates are increasing. So as you can see, overall there's a change in the color from being blue on the left side to becoming orange and red. If you look at the prevalence of complications, the major complications that we are speaking of are the microvascular complications like retinopathy, neuropathy and nephropathy, and then the macrovascular disease like the presence and development of heart disease and stroke, the major vascular complications. We are saying that the vascular complications, particularly the macrovascular disease, the strokes, cardiovascular disease, are much higher in the South Asian population. But if you look at problems like retinopathy and neuropathy, probably they are a little lesser than what you would see in the Western countries, and nephropathy is equally high again. So there's a comparison between what is seen in our population versus the UK population. As you can see, nephropathy, there's an increased risk in our population relative to the wide European population, and retinopathy also there's increased risk. The CVD is probably much higher. This is probably because of lesser use of statins and antihypertensive drugs in the South Asian region, more of uncontrolled glycemia, higher dyslipidemia at a younger age. Peripheral neuropathy, however, has a lower prevalence in our population. PVD also has a lower prevalence. This may be because of lower rates of smoking, or it may be because of the fact that we have lower heights as compared to the European population. We tend to have higher rates of insulin resistance, and we also see that we have a poorer insulin secretion because of an impaired beta cell reserve. Once again, this is because of several genetic and early life environmental influences which can program the beta cells towards lower insulin secretion, which has all been shown in different studies by very eminent researchers across the country. Our population has a greater ectopic fat deposition, and that fat is deposited in the visceral compartment and also around the liver, the pancreas, and these lead to impaired insulin action in the liver and also impaired insulin secretion from the pancreatic beta cells. So what we see is that South Asian populations have 30% higher intramuscular fat than BMI matched Europeans, and this factor was contributing towards the progression from pre-diabetes to diabetes occurring at a much faster rate amongst the Indian population or the South Asian population as compared to the European population. There is a lower lean mass because we said there's increased abdominal fat, increased visceral fat, increased ectopic fat deposition, and so we find that there is also a lower lean mass, and the Asian males and females had significantly lower lean mass compared to white and black males and females. So this is clearly seen from different studies across different parts of the world. Occurrence of diabetes occurs at a younger age in our population, and we tend to have diabetes occurring at a lower body mass index, and we tend to have certain phenotypic differences, as we said, that we tend to have poorer insulin secretion, and the insulin deficiency is probably the major driver of type 2 diabetes in young Indians, unlike in young European individuals in whom obesity and insulin resistance predominate in people with type 2 diabetes. We have a distinct Asian Indian phenotype, which is characterized by a higher waist circumference, higher waist to hip ratio, higher quantity of visceral adipose tissue, increased insulin resistance, and higher prevalence of atherogenic dyslipidemia, and in association along with the insulin resistance, there is also an early beta cell defect. And because of it, we see that diabetes occurs at a younger age, at a lower BMI, with a higher prevalence of coronary artery disease, lower prevalence of peripheral vascular disease, and possibly less of certain components of the microvascular disease, but almost equal occurrence of nephropathy. So the Asian Indian phenotype, as you can see, leads to increased prevalence of type 2 diabetes, which has a unique clinical profile. Now at this stage, it's very important to highlight this recent study which was published just on March 31st on 2022 in the PLOS One, and I was one of the authors of this study, where we have studied the newly diagnosed patients with type 2 diabetes across the country and who were presenting to various clinics across the country, and they had duration of diabetes of less than 1 year. And what we found was that amongst these 5,000 subjects who were studied, they had a mean age of 48 years, and they had hypertension which was present in almost 42% of these individuals, and almost 80% of them had at least one lipid abnormality, and almost 21% of them had history of tobacco use, either in the form of smoking or other forms of tobacco use, and 11% of them had chronic kidney disease. Almost 66% of this population of 5,000 individuals with new onset of diabetes had a BMI more than 25, which qualifies for the diagnosis of obesity in our population. Although we tend to have diabetes at a lower age, but we have a high prevalence of hypertension, and we have higher HbA1c levels. More than 50% of them had HbA1c levels of more than 8%. Some of them even had HbA1c levels of more than 10%. That means even in the first year, we were saying that these are not immediate at the time of diagnosis of diabetes. We are seeing patients in the first year of their diabetes. That's when it is very crucial that we should manage diabetes very well. And moreover, what we see is that they have a high prevalence of hypertension, they have a high prevalence of lipid abnormalities. Almost 80% of them have some form of lipid abnormality present, and this puts them at a very high risk of developing vascular disease. From all these, we could see that almost 60% of individuals, of these individuals with early onset diabetes, had a very high risk of cardiovascular disease because of the clustering of these risk factors, namely low HDL cholesterol, hypertension, smoking, and presence of CKD. And age here is a little confounding, because what we are saying is that at the age of 48, they have a significant cardiovascular risk. And one interesting observation which we have seen over the years is that we have something called as rule of halves. That is, half the people with diabetes do not know that they have diabetes, and even those who know about diabetes, they feel that diabetes is a very mild disease because they are asymptomatic, they do not want to take treatment for it, or they go for very alternative therapies, and they're not effectively managed. And even those who are taking treatment, we know that most of them may not be at glycemic control. We find that just about 25 to 30% of them are reaching the target of HbA1c of less than 7% or less than 6.5%, as we may want in the first year following diagnosis of diabetes. And what we see is that when you look at a comprehensive target of blood pressure, blood lipids, and the blood glucose control, we see that just about 6% of our patients are reaching all these targets. How we should go about managing our patients with diabetes? We look at the ADA guidelines, very elegantly speak about looking at what the different algorithms have been saying.